The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and good afternoon also. And welcome to the first webinar of 2021 for liver elastography and for the breast and thyroid elastography and how they can change the day-to-day work of your and help you in diagnosis. That will be explained by Dr. Harjot Singh. Dr. Harjot Singh is a leading doctor in India and is from the northern part of India and is renowned for his skills in shear wave elastography and for ultrasound skills. And he is a renowned radiologist in Punjab. So let me give control to Dr. Harjot Singh and he will start his presentation. Thank you, everyone. Over to you, sir.
Sure. Thank you, Abhishek. So nice of you. And I think Abhishek, is my screen visible?
No, sir.
Not visible right now.
I think now you get a presenter right.
Yeah. Got it. Is it visible now?
Yes, sir.
So hello everyone. I'm Dr. Harjot from Punjab. Today we will be discussing elastography, starting with introduction and principles of elastography. Then we'll move on to liver shear wave elastography, and then some interpretation of breast elastography. So, starting with introduction and principles of elastography. Evaluation of tissue stiffness has been used for thousands of years to diagnose the diseases. Many disease states lead to changes in liver lesion stiffness, most notably the cancers. These changes have been assessed by clinical palpation for ages. Elastography is a new imaging technique that can produce image based on tissue stiffness. The strain elastography was developed first. It assesses tissue changes when an external force is applied, either with a transducer or via patient respiration or heartbeat. Tissue stiffness do not the stiff tissues they do not deform, while the softer tissues do when a force is applied. With all strain-based techniques, the amount of force applied is not known and hence quantitative stiffness cannot be measured. Thus, strain elastography is a qualitative technique. Some semi-quantitative methods have been developed where the stiffness of the tissue of interest is compared to the stiffness of standard tissue in the field of view. So this thing is known as strain ratio. For example, the stiffness of a thyroid lesion can be compared to the adjacent normal thyroid tissue. The cutoff value comparing the relative stiffness of the reference standard can be determined through which one can differentiate a benign lesion from a suspicious for malignancy. The second major technique is shear wave elastography. Here, a mechanical force or an acoustic radiation impulse is used to generate shear waves within the tissues. The shear waves propagate perpendicular to the applied force, just like ripples in water when a stone is dropped on it. The ripples they correspond to the shear waves, whereas the stone corresponds to the force applied. So here's an image. We can see the ripples. So these are the shear waves generated by the force of a stone or any force which was applied by the transducer. The shear wave speed can be estimated by observing the tissue motion in response to shear waves using B mode ultrasound. The shear wave speed is dependent upon the tissue stiffness. It is slower in the softer tissues and faster in the stiffer tissues. The technique, when performed with mechanical pushes, and when no ultrasound image is acquired. It is called transient elastography, also known as fibroscan. So this is a model where we can see there's a push pulse was placed here. The push pulse enters this part. So this is a jelly. We can There will be pulses generated this way. The ROI can be placed, and the velocity in stiffer tissue can be seen, and which will be faster than the soft ones. The point shear wave. A single small region of interest can be placed in a tissue of interest, and ARFI pulses used to generate shear waves. The resultant shear wave speed is then calculated and displayed. It usually represents the mean value of shear wave speeds within the region of interest. Coming to 2D shear wave, multiple ARFI pulses can be applied over a large field of view to estimate the shear wave speed over that large area of tissues. Whereas in point shear wave, just a small area can be used. Color coding of pixels in display map is used to visualize the variation in shear wave speed in the FOV using 2D elastography. The conventional color coding here is stiff for red and soft for blue, whereas in strain it is opposite. The soft ones are red and the harder ones are blue. With both strain elastography and shear wave elastography, it is important for the transducer to remain in one location during the data collection to limit motion in the field of view. The motion either by the transducer or from the patient will result in poor quality of the data. Another critical factor here in performing elastography is the pre-compression. Pre-compression is basically the amount of force applied to the tissues when acquiring the images. It's the force like when you or how hard you press while doing the ultrasound, while doing the elastography. As the tissues are compressed, they become stiffer than the original. This results in a difference in the data collection. So what will happen is the softer tissues, the fat or the superficial ones, the softer tissues, they tend to become more stiff than the already stiff tissues. Thus, the pre-compression reduces the contrast of stiffness between the originally soft and the stiff tissues, hence the poor quality of data. What happens is, while doing the breast elastography, when we press the probe very hard down, the fat will be compressed. The superficial fat there will be compressed. That soft fat will become now hard just because of the pre-compression. Hence, the contrast between a lesion down in the gland in the breast and the fat will reduce. So the poor quality of data. So this is an example of pre-compression. Normally, the shape. Suppose a lesion is here. The shape of it is round. There is no pre-compression. We can see it properly. Whereas while we compress it, its density will increase and it will become more stiff. So the contrast between a soft tissue and a proper hard tissue will decrease. The effect of pre-compression is more evident in superficial tissues such as breast than in tissues which are deep like the liver. Hence, the elastography images of both shear wave and 2D shear wave should be used using a light touch. Poor shear waves may be generated during both point shear wave and 2D shear wave. All the vendors have rejection algorithms that evaluate the quality of shear wave generated. The different vendors provide different kinds of propagation maps to evaluate propagation and dispersion of the shear wave to assess the quality of shear wave generated. Coming to strain elastography now. Strain elastography determines the relative strain or the elasticity of the tissue within the FOV. The more the object deforms, the higher is the strain and softer is the object. The less the object deforms, lower is the strain and stiffer is the object. To determine the strain, The external force is applied and how the tissue changes its shape is monitored. The force can be very minimal, such as patient breathing or his or her heartbeat, to moderate rhythmic force generated by the transducer movement. The strain elastography is performed by evaluating frame-to-frame differences in deforming the tissue when the force is applied. The real-time strain image is displayed with a scale based on relative strain on the tissues within the FOB. Here, the value of absolute strain modulus, the Young's modulus, which is a numerical value quantifying the stiffness, cannot be calculated because the amount of force cannot be accurately determined. Like how hard we are pressing, we cannot quantify the force here, so we cannot calculate the Young's modulus. A simplified version of the principle of strain will be, we can see jelly or gelatin, and there's an element in it. So this is gelatin with an element. So what happens when we apply stress? Like we are compressing it with a spoon, the gelatin changes the shape because it is soft. While the element here, it does not change any shape because it's stiff. So similarly, this is fat and other normal tissue, whereas this is a lesion. So what we can expect using doing a strain elastography examination is these soft tissues, the normal tissues, they'll be easy to deform, whereas the lesion will be hard and it won't deform, and we can get good results. The ultrasound system compares frame to frame changes of the tissue when the tissue is compressed and released. The tissue that deforms the most are considered soft, as earlier also told, while those that deform the least are considered stiff. The technique required to obtain optimal strain images varies within the algorithm used by the manufacturer. With some systems, very little, if any, manual compression release is needed, while with others, a rhythmic compression release cycle is required. Compression release technique for a specific system can be learned with experience and practice only. Like all different systems will have different algorithms and different compression release. Applying like too much compression release with like when we are pressing it so hard and releasing, it will lead to image noise. And when we are not applying any compression release, it will result in like no image. So hence a sweet spot, like how much hard to press and how much compression release to be given, at what rate it's to be given. So that speed spots, it varies machine to machine, and that can be learned through experience and practice only. Some vendors, they have a visual scale also that helps to confirm the optimal compression release and the frequency that is applied. But other factors in obtaining optimal images, so high quality factor alone, that does not guarantee optimal images. There are many other factors also. The lesion, the main thing is the lesion should appear similar in all frames of strain elastography. If not, then there is uniform displacement of the lesion during scanning, or an unacceptable pre-compression is being applied. Uh, the compression release, what we are doing is, it should be orthogonal to the plane, perpendicular to the lesion. So I'll show you an image also. Monitoring of the B mode image to confirm the lesion is only displaced in depth during the scanning, and only moving axially in the field of view will allow for the optimal images. Positioning of the patient so that the breathing or other motions, such that from heartbeat is like it should be parallel to the transducer, and they can be negligibly, they'll be negligible to interfere in anything. Strain images, they are generated basically from the raw data of a B mode image. Hence, it is important to obtain quality B mode images before activating the strain elastography mode. If there are areas of shadowing, they'll degrade the quality and accuracy of the elastogram. Another important tip here will be uh, placing the palm of the hand on the patient will help stabilize the transducer and will allow for more sensitive movements. So this is an image. You should place your palm on the patient. So that will it will very helpful so that you'll be able to stabilize the probe and the lesion, and small sensitive movements can be made. Another thing is, suppose this blue thing is lesion. So the compression release should be orthogonal to the lesion, like perpendicular to it, straight down. This thing should not be done. Like here is a lesion, and it should not be compressed like this at an angle. If same variety of tissues are included in each image, a relatively more constant color display will be obtained. For example, in the breast strain elasto, if a portion of pectoralis muscle, the glandular tissue, and some fat also is included in the FOB, a more consistent elastogram will be obtained. The fat being the softest and the pectoralis muscle the stiffest, the color scale or the dynamic range will be fairly constant. Like the softest is the fat, hardest is the muscle, and other lesions in between. So, however, if a breast cancer, which is more stiff than a pectoralis muscle, is also present, so that can be easily detected. So, on strain wave, in a color display of a lesion, will have the same color regarding of the tissues present in the FOB, whereas in strain elastography, the lesion may appear of different colors if other tissues are present in the FOB, as the strain will give relative stiffness, whereas the shear wave will give absolute values of stiffness. So coming to the interpretation part, there are three methods of interpreting strain. One is evaluating the size change between the B mode image and the elastogram, known as the EB ratio. Second is various color scales, and the third is the strain ratio, that is the ratio of lesion stiffness to that of a reference tissue. EB ratio. The breast cancers, they appear larger on elastograms than on the B mode. The benign lesions, they appear smaller as compared to the corresponding B image. The reason is the breast cancers on any malignant lesions, that will be very hard, and the surrounding tissue of the lesion will also be a little bit stiff. Hence, the breast cancers, they will appear larger on the elastograms than the B mode image. Either the lesion length ratio or the lesion area ratio can be used to evaluate the EB ratio. The lesion is measured in the same position on both the elastogram and the B mode images. The sensitivity of this technique is quite high, approximately 98%. The EB correlates with the breast tumor grade. I'll show you images. I'll discuss the color scale images and EB ratio together. Color scales. Various 4-point or 5-point color scales have been proposed to evaluate the elastograms. The 5-point color scale system, the SCUBA score, has been proposed to classify the breast lesions using strain elastography. The SCUBA score or the SCUBA scale combines the ratio changes, the EB ratio, and the degree of stiffness of the lesion also. So higher the scores, higher confidence for malignancy. So this is SCUBA score. We can see this is a B mode image. It's just a graphical representation. This is a B mode image, and these are the elasticity images. So this is the lesion appears totally green. So the lesion is soft. Score 1, it is benign. Coming to score 2, there is mosaic pattern of blue and green. Third, the lesion is predominantly hard. It is blue, but the lesion on strain on the elastogram looks smaller than the lesion on the B mode. Hence, the EB ratio is less than 1. So this is also probably benign. So equivocal or benign. The third is, the fourth one is blue. It is hard. The lesion on the elastogram is of the same size of the lesion on the B mode. The EB ratio being 1. So this is this lesion should undergo biopsy to confirm for the malignancy. Score 5. the image showing the lesion on elastogram is bigger than the lesion image on the B mode. So EB ratio greater than 1. So this probably is malignant, but still it should undergo biopsy. Another thing is some cystic lesions are there. So these cystic lesions, if we are using colored images, then it will show a mosaic pattern of blue, green, and red. And if a simple black and white image is being used in Elasto, then it will show bullseye artifact. So scuba score 1, these are true images when I B mode and the elastogram. So scuba elasticity score 1, it is benign. Here is a lesion which is coming out to be totally green here. So benign. Second, another lesion, benign. There is a mosaic pattern here. We can see some blue, some green. So it's a mosaic pattern of blue and green. Again benign. Coming to scuba score 3, which is probably benign. Here is the lesion. Some parts are blue, some parts are green, but the blue part, it's basically blue, but it has some green parts. The blue region, the hard region, is smaller than the lesion on the B mode. So hence, EB ratio less than 1, scuba score 3. Scuba score 4, the lesion here coming out to be blue, and it is almost of the same size. EB score 1, probably malignant. Elasticity score 5, the lesion, whereas on elastography images it is appearing bigger than the lesion on B mode, so malignant. Coming to another this thing, so the here it is totally green, score 1 totally green. It's prevalent in benign lesions as well as simple cyst. If it like a completely cystic lesion, it will show BGR pattern, blue green red, a mosaic pattern. Score 2, I have shown the same image earlier also. Coming to strain ratio, the ratio of lesion stiffness to that of another tissue that has fairly constant stiffness is a semi-qualitative method of evaluating the strain. For the breast lesions, the strain ratio offers like this is it's a ratio of strain in the mass of the lesion to that of strain in the subcutaneous fat. The region of interest should be taken at the same depth from the skin to limit the errors of from differing compression at different tissue levels. So this is basically lymph node. So what we can see is this is the muscle, the strap muscle, lymph node. So when a strain elastography image was obtained, so this A was giving a value of 0.23, whereas it was compared to the muscle part here. It was showing 0.84. So the strain ratio was 3.64. I'll tell you the cutoffs also again. More than 3 for strain ratio, we take it for malignancy. Coming to pre-compression, the pre-compression can significantly change the strain value of a reference tissue. As the pre-compression is applied, the stiffness of all the tissues increases. Stiffness of some tissues will change more rapidly than the others, like the fat, the superficial tissues, they'll be pressed more, and their stiffness will increase more rapidly than the others. Therefore, with pre-compression, the strain ratio of lesion to the fat will decrease and it will give us false values. The cutoff value to distinguish probably benign from probably malignant lesions, it can vary greatly. The results vary between different vendors as the stiffness is calculated differently from different systems. So basically it is machine based. So the appropriate cutoff in your lab should be determined with your technique and your equipment. So it is like it varies from machine to machine and person to person how hard the someone is pressing. So it is basically your equipment and your technique which gives you the appropriate cutoff. To summarize, if a lesion has the same stiffness as fat in the lesion image, the lesion should be considered to be a lipoma. If a hypoechoic breast lesion has similar stiffness to that of glandular tissue, so it is most likely benign, either a fibroadenoma or some fibrocystic changes. The malignant lesions will be much stiffer than the glandular tissue. Some tips and tricks here. We should keep the FOV large enough to include tissues with varying stiffness. This will maintain a more constant color map and a consistent dynamic range of strain values between the images. So we should maintain a FOV where the lesion of interest is less than 50% of the FOV. We should use the B mode images to determine the amount of tissue displacement being applied. Maintain the transducer perpendicular to the lesion in the motion of the plane. Use appropriate technique for your system. Use the B mode image to confirm the scan plane through the lesion remains constant. Position the patient so that the displacement motion is in the plane of the transducer. Do not apply pre-compression. Use a light touch and compare the lesion stiffness with that of other tissues like in breast, fat, and normal breast tissue. Have the patient hold still and maintain uniform shallow breathing. There should be no talking during the data acquisition. Turn off the background B mode on the elastography image if a grayscale map is being used for the elastogram. Remain in a stationary position while acquiring data. Do not survey. And acquire static and also acquire the cineclips. Coming to shear wave elastography. In this technique, an initial ultrasound pulse or ARFI is applied to the tissue, which induces a shear wave perpendicular to the ultrasound beam. Conventional B-mode ultrasound sampling techniques are used to calculate the velocity of shear wave generated through the tissues and monitoring the tissue displacement caused by the shear wave. From shear wave speed through the tissues, the strain modulus, the Young's modulus can be calculated. The shear wave speed is directly correlated with the tissue. So I've shown this image earlier also. The push pulse enters from the upside up here. Waves are generated. Transverse shear waves are generated. These are detected in this box, and the velocity of these waves is calculated using B mode images. Velocity will be stiffer. Velocity in some stiffer tissues will be faster than in the softer tissues. The stiffness, higher shear wave speeds represent higher stiffness. Stiffness can be displaced as shear wave speed in meter per seconds or also in Young's modulus in kilopascals. With shear wave elastography, a quantitative measure of lesion stiffness is obtained either in point shear wave or over a larger field of view with pixel to by pixel color coding of the shear wave speed. This is known as 2D shear wave. If we are using just the point of interest, then it is point shear wave. In point shear wave elastography, the region of interest, approximately 1 centimeter cube, is placed at the site of interest, and a single measurement at the site of shear wave velocity is obtained from that location. Whereas in 2D shear wave elastography, multiple measurements are obtained in a larger field of view and displayed during using a color coded map. And ROI can be placed within the FOV to multiple can be obtained. Rather, I'll say multiple one or more than one ROIs can be can be placed within the FOV to obtain shear wave elastography at the location. The quality measure is determined by the amount of tissue displacement and the signal to noise of the tracking pulses. The recommendation is to obtain multiple measurements and use the mean value for diagnosis. For example, the recommendation in liver case, in the cases of liver, the recommendation is to obtain 10 measurements and use the mean value. With 10 measurements, we can get the interquartile range also, the IQR, and this can be used to determine the quality of the measurements. In 2D shear wave elastography, on the image to be used for measurements, one or more than one ROIs can be placed to obtain the stiffness values. Most systems, they allow for ROI size to be changed as desired. The color-coded image shows determination of stiffness values over a larger area. The area of maximum stiffness and the stiffness heterogeneity can be quickly identified. Here, the red always codes for the stiff and the blue for soft, whereas in strain, the blue was for hard and red was for soft. Some tips and tricks: keep the FOV slightly larger than the lesion to evaluate the surrounding tissue. Maintain the transducer perpendicular to the skin. Hold the transducer still and ask the patient to hold his or her breath during the measurements. Wait 2 to 3 seconds after asking the patient to stop breathing before acquiring the data to allow for the structure to stop moving. Do not apply pre-compression with the transducer. When using real-time shear wave imaging, allow several seconds for the image to stabilize before taking a measurement. That will be all in just the principles of elastography. Now I'll be starting with liver 2D liver elastography. Coming to liver elastography, the clinical aspects of shear wave elastography in HCV-induced liver fibrosis. Liver fibrosis. Many injuries can cause changes in tissue stiffness, especially the tumors and the fibrosis. Liver fibrosis, it is a common pathway for several liver injuries. Viral hepatitis, HIV, HCV co-infection, autoimmune, hereditary, metabolic, and toxin-mediated liver diseases, all these can result in hepatocellular dysfunction, expansion of the extracellular matrix with distortion of the hepatic architecture, portal hypertension, and finally liver cirrhosis. The degree of liver fibrosis in chronic viral hepatitis has major clinical implications, and presence of advanced fibrosis or cirrhosis determines the prognosis. Conventional images technique, they do not provide information about tissue mechanical properties. Uh, uh, but a liver, basically HIV, HCV liver. Short definitions. What is fibrosis? Fibrosis is abnormal increase in collagen deposition and other components of the extracellular matrix in response to the chronic injury. Cirrhosis, it is a diffuse process characterized by fibrosis and then conversion of normal liver architecture into structurally abnormal nodules. So this is how cirrhosis develops from a normal liver. So uh, a normal liver, some chronic injury to normal liver like viral infections, alcohol, non-alcoholic fatty cirrhosis, autoimmune disorders, cholestatic disorders, metabolic diseases. So all these things will lead to inflammatory damage, matrix deposition, parenchymal cell death, and angiogenesis. So this is early fibrosis stage. So early fibrosis can stop here or move forward to cirrhosis, or it can resolute back to normal liver. So from this early fibrosis stage, there will be disrupted architecture, some loss of function, aberrant hepatocyte regeneration. So this will lead to cirrhosis, liver failure, portal hypertension. So cirrhosis can also regress to early fibrosis. Otherwise, like if it moves further, then we need to get a liver transplant, or there can be a hepatocellular carcinoma. Acute hepatitis C, 15% of the patients get resolved, and some 85 move into chronic HCV. From these 85, approximately 80% become stable and 20% develop cirrhosis. From this 20%, 75 are slowly progressive, whereas 25% they lead to hepatocellular carcinoma and liver failure. So total like acute HCV patients, from the total load, 4% cases develop liver failure. Coming to complications of advanced liver disease. Clinical portal hypertension, thrombocytopenia, varices, nodular liver, then impaired hepatic function, albumin deranged, bilirubin deranged, INR deranged. So this goes to decompression. Advent of complications are like ascites, encephalopathy, variceal hemorrhage, jaundice. So different levels of fibrosis exist, which in practice are assessed using a histological score. The most widely used one is Metavir score, which incorporates 5 stages: F0 to F4. F0 is no fibrosis. F1 is portal fibrosis without septa, minimal fibrosis. F2 moderate fibrosis. Here there will be portal fibrosis with few septa. Then F3 will be severe fibrosis, portal fibrosis with many septa but without cirrhosis. F4 proper cirrhosis. Coming to assessment techniques can be divided into two major categories: invasive and non-invasive. Invasive is the biopsy. Non-invasive can be further characterized into two: the serum biomarkers and imaging. We will be talking about imaging here. Imaging of two types: ultrasound based and magnetic resonance based. Ultrasound based is shear wave or real time. The real time was developed by Hitachi. It is non-FDA approved. So we'll come to shear wave. Shear wave based is again external mechanical impulse, that is the fibroscan or transient elastography. Then it can be focused acoustic beam. This focused acoustic beam is either ARFI, the point shear wave developed by Philips and Siemens, and other is 2D shear wave elastography. Invasive. Liver biopsy is an invasive technique and has been the standard of care of fibrosis assessment for years. Has several limitations and procedure-related complications. About one-fourth of the patients undergoing biopsy, they have pain in the right upper quadrant or the right shoulder. Severe complications are very rare, but they do exist, ranging from 0.05 to 5%. So, graphical representation of liver biopsies. Part of some small tissue is taken out from using liver biopsy and assessed under a microscope. The major drawbacks in a case of biopsy are patient reluctance, adverse effects, the accessibility, effective cost, sampling errors, and inter-observer variation in staging. A. Regev et al. They reported about 33% of the subjects were graded to have a difference of at least one stage between the right and the left lobe of the liver. So performing liver biopsies on a large scale, it is very unreasonable, not cost effective, and it is not practical also. Coming to elastography, we have five main groups: transient elastography, shear wave, acoustic force impulse ARFI, real time technique, and magnetic resonance elastography. The transient elastography, also known as fibroscan, it was approved by FDA in 2013. Uses mechanically generated elastic shear wave and follows its propagation throughout the liver to measure its speed in a single dimension. The speed of shear wave is directly related to the stiffness and the level of fibrosis. So this is how transient elastography is done. The probe here, it gives a mechanical impulse, and the speed of that impulse traveling through the liver is calculated. Different modes of elastography. The transient or the fibroscan, it was the first commercially available ultrasonic shear wave measurement system. It is non-invasive, based on vibration controlled transient elastography. It is very accurate and allows a correct classification for cirrhosis in 94% of the cases, and around in 57 to 90% of cases for important fibrosis. For a study to be adequate, the success rate is the ratio of valid measurements to the total number of measurements should be higher than 60%. The interquartile range, it reflects variation among the measurements, and it should be less than 30% of the mean liver stiffness measurement values. Some of the limitations of transient elastography are: it is a blind technique. The left lobe of the liver cannot be examined. It is difficult in cases with the BMI of greater than 30. Acute inflammation, elevated STD levels, it will show false high values. Cannot be used in cases with ascites or with active alcohol intake. Some extrahepatic cholestasis, passive cardiogenic congestion, food intake, all these things will show us false high values in operator experience. And the other part is this system cannot be coupled with standard clinical ultrasound and cannot give morphological examination. In a study of around 13,369 chronic liver disease patients, over a period of 5 years, unreliable results were obtained in around 15.8, like around 16% of the cases. The limitations of transient elastography, such as difficulty in measuring obese patients and the patients with narrow intercostal spaces, the variation in operator experience, and the fact that it is not applicable to the patients with ascites. These were the primary factors contributing to unreliable results. Issue of obesity has been partially resolved by introduction of a XL probe that measures liver stiffness deeper than the standard M probe. Coming to acoustic radiation force impulse, developed by Philips and Siemens, also cleared by FDA in 2013. It's a quantitative technique that provides a single dimension of liver stiffness measurement over a predetermined sample box in the liver. The ROI here is smaller than 2D shear wave. Correlation of histological fibrosis was not significantly different from transient elastography in comparison to the ARFI. However, the transient elastography is better in predicting the presence of liver cirrhosis. So earlier stages can be easily detected using ARFRI, but transient elastography uh, is better in cases of fibrosis. It better detects fibrosis earlier and in a better way. Advantages over fibroscan here, it provides visual control of the measurement location, which is not possible in transient elastography. Fibroscan, basically it's a blind technique. We do not know where the measurements are coming from. Here in acoustic radiation force impulse, we can see we have a visual control. So we can avoid vascular structures when taking measurements. We can study the regions of interest like the areas of stenosis or liver with tumor. We can correlate elasticity to the tissue architecture. We can study both right and left lobes of the liver. We have the ability to select the measurement depth also. And the best part is it is incorporated onto a conventional ultrasound system. Real-time elastography, it was developed by Hitachi. It's based on strain imaging induced by manual compressions. It is less accurate and not cleared by FDA. Coming to magnetic resonance, cleared by FDA in 2009, it is coupled to conventional MR imaging protocol, involves 3 steps. Propagation of shear wave within the liver from driver source generating continuous 60 Hz acoustic vibration. Imaging the propagating shear wave in the liver using MR sequence with motion encoding gradients, and then processing the information in wave images with an inversion algorithm to generate quantitative elastogram or stiffness maps that measures stiffness in kilopascals. So the limitations here are if there is high hepatic iron content, we'll get false values. Inadequate breath hold and claustrophobia is a major point, and the high cost. There was a paper published in Ultrasound in Medicine 2017. It says the transient elastography is the most widely studied method outside the radiology practice, but a considerable amount of evidence regarding other methods have been published. The results obtained by point shear wave and 2D shear wave, they show similar accuracy as compared to the transient elastography for assessment of liver stiffness, with a potentially higher applicability because transient elastography or fibroscan is a blind technique, whereas 2D shear wave or point shear wave, we can see and see the liver and assess the morphological information also. The shear wave elastography method, it is point shear wave, takes a measurement in a small ROI. This is how point shear wave is used. We are placing a small ROI here. Only this part of the liver is being assessed. Whereas in 2D shear wave, we can take multiple measurements over large field of view, and ROI can be placed in a sample box. So this large color coded box, so this is a dispersion map. It's for quality control, the green one. So this is a 2D image from a 2D shear wave image. So we have a very large area of the field of view. So we can place multiple ROIs here also for measurement. Q elasto shear wave elastography by Esote, an ultrasound based method for non-invasive quantification of liver fibrosis. Q-Elasto embeds it's a patent technology of Esote for innovative motion artifact correction plus advanced algorithm for smart selection of reliable measurements. So the 3D wave here, it is basically for the quality control, like how good measurements we are taking, how reliable measurements we are taking. So following a shock, inside the gate is acquired multiple and very fast samples of consistent perturbations on tissues. So it provides an immediate feedback about the quality of shear wave produced in the tissue. So this graph, so here the graph is wavy. So it's a wrong method. Whereas here we can see the graph rising quickly up here and coming down. So this is the correct graph, and this tells that the measurement what we have taken is good. So that we are using three-dimensional axis here, the space, time, and the displacement. So the color scale, the blue is for low displacement and red is for high displacement. Coming to 2D shear wave elastography, cleared by the FDA in 2014, based on shear wave induced by multiple focused acoustic beams and a very rapid acquisition of ultrasound images. The application is able to acquire to capture the propagation of resulting shear wave in real time and a large area of liver parenchyma, developing real time image. The region of interest is fan shaped and larger than the other modalities. Unlike the fibroscan, predetermined anatomical site of liver parenchyma without any vascular structures can be evaluated. The principles are it assesses liver stiffness by measuring the velocity of elastic shear waves in liver parenchyma. The shear waves are created by ultrasound generated pulses of an acoustic radiation force. The velocity of shear wave is then estimated by a Doppler like effect over the region of interest and is related to stiffness or the elasticity of the medium. Stiffer the liver, higher is the velocity of the shear wave. The measurements are not limited by the presence of ascites, as the ultrasound beam generated by the shear wave, it propagates through the fluids. Unlike the fibroscan, the limitation of ascites has been removed, and we can easily get shear wave images and shear wave data in patients with ascites also. So this is how we take 2D shear wave measurements. A large FOV. So this map is for quality control, and this is how we get a FOV and measurements from here. Guidelines for performing shear wave elastography are: it's performed using convex ultrasound probes with integrated technological solutions, allowing elasticity imaging and measurements. Like the probe and the machine should have 2D shear wave. It should be 2D shear wave compatible. The measurement should be taken at intercostal space in spine or in left lateral position with the right arm in extension. I personally use the left lateral position with the right arm in extension. The measurement should be taken at neutral breathing. We should ask the patient to hold his breath, wait for like 2 seconds or 3 seconds, and then take the measurement. The measurement should be taken at least minimum 15 mm below the liver capsule, or you will get false high values. The patient should the patient should fast for at least 2 hours before the exam. Otherwise, you will again get false high values. Uh, the most important point before before applying a 2D shear wave mode is good B mode liver image. Adequate B mode image liver image is a prerequisite. Some potential confounding factors are liver inflammation, as indicated by raised AST/ALT levels. It will give false high values. Obstructive cholestasis, liver congestion, acute hepatitis, and some infiltrative liver disease. All these will give false high values about the fibrosis. At least 10 liver stiffness measurements should be obtained as and result expressed as median together with IQR. Uh, 10 was the standard using point shear wave, but nowadays using 2D shear wave, they say that even 5 measurements are good enough. But still, at my place, at our center, we use 10 measurements, 10 liver stiffness measurements using 2D shear wave also. Interquartile range, it should be less than 30%. This is the most important reliability criteria. Lowest variability is obtained at 4 to 5 centimeters from the transducer. So, what to do and what not to do? The whole echo image is to be visible, no unexpected shadowing. Not to do, like we should not take measurements like here, we are getting rib shadow, and this should be avoided. FOB, placing the FOB here should be avoided. Position the box at least like 1 to 2 centimeter below the capsule in orthogonal axis. Do not place the capsule where reverberation artifacts from the Glissen's capsules are there. And do not place the capsule, do not place your box in a position which is not orthogonal to the Glissen's capsule. Measurement selection. According to guidelines, like new guidelines, 5 valid measurements have to be obtained in 2D shear wave. It is better if the standard deviation is less than 30 for each valuation. The session can be reliable when IQR is less than 30. So what we are getting is standard deviation here and the measurement here. The standard deviation should be less than 30 for each measurement. This gives a higher reliability. Second is the IQR. 5 measurements taken. So the IQR, look, the IQR here is 10. So this gives a higher reliability and high quality data. It means that we have acquired a high quality data. And coming to, I'll show some another thing. So this is a dispersion map. This is a quality map. And this is the where we take measurements from. So look here, what we have got is, there is a vessel going down here. This is the black one. And when we see the quality map, we see this is bit dark and we are getting some orange color here. So the orange color shows the low quality data. So in such conditions, when we place the ROI, the ROI should be done in a data here, which shows high value, the green data. So the green, if we take the measurement at green data, it is a reliable measurement. Advantages: it is easy, painless, rapid technique, good interoperator and good interoperator reproducibility. Result is immediately available. It's incorporated onto conventional ultrasound system. Liver morphology can be assessed simultaneously. Quantitative assessment of soft tissue elasticity in kilopascals or meter per seconds is obtained. We have visual control over the measurement location, so we can avoid vascular structures. We can study the regions of interest like the areas of stenosis or the liver with tumor and correlate the elasticity of the tissue architecture. We can study both right and left lobes of the liver. Several papers have reported higher accuracy of 2D shear wave than the transient or the fibroscan. So, Bota S et al. They gave a meta-analysis of AFRI elastography versus transient elastography for liver evaluation, and they said that acoustic radiation force impulse elastography seems to be a good method for assessing liver fibrosis and shows higher rate of reliability measurements and similar predictive values to transient elastography for significant fibrosis and cirrhosis. So, Babu et al. They did another non-invasive technique for in vivo liver fibrosis evaluation using supersonic shear wave. According to them, also 2D shear wave and point shear wave performed better than transient elastography. Another paper was published by Ferrioli et al. It was a pilot study assessing liver fibrosis in chronic hepatitis. So Ferrioli et al. They compared shear wave elastography and fibroscan by calculating the ROC values and found that shear wave performs better than transient elastography to diagnose significant fibrosis. So F0, F1 as compared to like F2 from F4, shear wave had higher values than the transient elastography. Again, in the next part, F0 to F2 compared to F3 to F4, again high values than transient elastography. And F0 to F3 compared to F4, again high values. So the shear wave performed better than transient elastography in all the stages. Some of the limitations are the BMI greater than 30. Yes, the image won't be good. Acute inflammation, elevated AST levels, false high values. Active alcohol intake will give false high values. Extrahepatic cholestasis will give false high values. Some passive cardiogenic concession will give false high values. Food intake will give false high values. And operator inexperience. Clinical applications are chronic viral hepatitis, diagnosis of non-alcoholic fatty liver disease, diagnosis of alcoholic liver disease, assessment of end-stage liver disease or disease after liver transplant, assessment of focal liver lesions, a liver elastography malignancy prediction score, assessment of autoimmune liver disease. So here I'll ask, is this valid or not? Here the measurement. Can you like? I don't have a. I don't put a poll. Anyways, if this measurement is valid or not, it is not valid. It's a bad acquisition with patient in full inspiration. Here we can see artifact here. This image is not clear. Presence of air in the lung we can see. The box is put in the artifact area. Dispersion map shows low reliability. And SD what we the standard deviation we are getting more than 30%. So if this measurement is valid or not, yes, this is a valid measurement. The dispersion map is good. Other map is good. The standard deviation is less than 30%. And this ROI we have taken this FOV and ROI is away from the vessel here. If this measurement is valid or not, no, it is not valid. Artifacts are coming, the dispersion map is not good. If this is valid or not a valid acquisition because the dispersion map here is wrong. There were reverberations here. The FOV is in reverberation area. The dispersion map here is showing orange, and here where the ROI has been placed, the dispersion map is showing small areas of orange color. So this is not a valid acquisition. Uh, this is how we take in real life images. This is how elastography is. Wait. I have a video here. I'll play a video. How liver elastography is done. This is showing point shear wave. So the first measurement was taken here. Look at the graph. The graph was good, immediately rising and slowly coming down. The second measurement here, no artifact in the image. E wave going up, red, and then coming down slowly. So high value here. Again a third image. That's good. Again a good image. Higher reliability. All the above five measurements, they showed higher reliability and they were good. Here the patient moved while acquiring. So we get a bad graph and a medium reliability. So this measurement has to be deleted and not to be counted. I can show it again. Here the patient moved. So we got a bad quality of graph. So this was not a reliable value. Sorry, I'll try it again. So our IQR like in seven uh, measurements, the IQR is less than 30. So all the data is valid. It's a good exam till now. Again, some artifact and we got a false value and it was deleted. Sorry, I'm showing you the image. So the total IQR we got was around 13. So it was a reliable exam and the results can be passed on. So coming to that was point shear wave. Coming to 2D shear wave. So we can use more than one ROIs here. So we cannot use the third one. Two was okay, third was overlapping, so it was not used. So in this exams we have not used the dispersion maps. So again two were used. The third we should not overlap the ROIs here. So all the 10 measurements acquired, and we had IQR of just 12. So this is how the graph is given, and the total values, the IQR, the standard deviations, the median, the average is given, and at what depths they are given. So coming to the scores, like when to call what metavir score to be reported. So these are different for different diseases. So hepatitis B has a different has different scores. Hepatitis C has different scores. Alcohol-induced liver cirrhosis has different scores. So in cases of hepatitis B, metavir F0 to F1 is less than 7 kilopascals. So this is normal. If the values are less than 7, so it is metavir F0 to F1, and it is normal. From 7.1 to 11.2, the metavir score is F2 to F3. It is mild to moderate fibrosis. So metavir score of 4, F4, that is severe fibrosis, will be given if the score values are more than 11.2. So this is the case of hepatitis B. Whereas seeing the hepatitis C, we have higher values. A normal will be less than 8, mild to moderate 8.1 to 17, and severe fibrosis more than 17. Whereas in hepatitis B, it was just 11.2. So in case of alcohol, normal F0 will give if it is less than 6 kilopascals. Again, normal F1 is normal, will give around 6.1 to 8 kilopascals, will give metavir F1. 8.1 to 11 will give moderate, mild to moderate F2. 11.1 to 19 we give mild to moderate F3, and more than 19.1 we give metavir F4 cirrhosis. That will be all in liver shear wave elastography. Coming to breast elastography interpretation, it's a small one. Most of the points, the principles we have already discussed in the first lecture. So here we'll be discussing just the interpretation of breast elastography. It is broadly classified into qualitative, semi-quantitative, and quantitative. Qualitative, generally less accurate. We use SCOBA scoring system. It's a color-coded scoring system, already discussed. It's a color-coding scoring system. The comparison of size of lesion is made between the B mode image and the elastogram image. The lesions that are malignant, they appear larger on elastographic images. The scoring system assigns a score of 1 to 5. 1 is complete deformability of the lesion. It's green and it's soft and appears green. Score 2, the deformability of large amount of the lesion with little bit of stiff areas. So it gives a mosaic pattern of blue and green. Score 3, presence of stiff area in the center with peripheral deformability of the lesion. So the EB ratio of less than 1, the lesion overall will appear blue. The lesion is smaller on elastogram than the B mode image, so the EB ratio less than 1. Score 4, it's a completely stiff lesion, blue in color, it is hard. The lesion on elastogram is of the same size as on the B mode image. Sorry, the EB ratio is 1. And score 5, the entire lesion and the surrounding area are stiff. It's blue in color, hard. The lesion on elastogram is greater than is larger than the lesion on B mode. So EB ratio more than 1. So here I've shown some. I'm showing some another images. So here we can see this is scuba score 1. The image is predominantly green with some yellow areas which are still more soft. So lesion is overall soft. This is scuba score 1. Scuba score 2, actually here I'll show you in this image. The strain ratio is also being calculated. So this was the area of the lesion compared to the area of subcutaneous fat, showing strain ratio of 1.05. Second, The area has of the lesion, the area is showing mosaic pattern of blue and green, scuba score 2, and the strain ratio when we see to the subcutaneous fat, it is 1.76. Scuba 3, blue, but the blue is small. The area of blue is smaller than the total lesion. So here we see a proper blue lesion here, but it is little bit small than the total lesion. Scuba score 4. This lesion is like total blue, and the area of this blue is larger than the area of the lesion. Scuba score 5. Score 1 is negative for malignancy, 2 to 3 equivocal for malignancy. I'll say 2 is still, we'll take it as benign, 3 is equivocal, 4 we take positive for malignancy, and 5 also. The lesions with score 4 and 5 should undergo biopsy. The lesions with score 1, 2, and 3, they are classified as benign. Simple breast lesions, they usually demonstrate bullseye artifact on black and white images if we are not using color elastography images. If we are using colored maps, then we'll see an aliasing artifact on color, the blue, green, and red pattern. This scuba score system has a sensitivity of 87%, specificity of 90%, and diagnostic accuracy of 88% to tell if the lesion is malignant, or the lesion is equivocal, or the lesion is benign. Coming to quantitative assessment, this method expresses the elasticity of lesion in units, that is either kilopascals or meter per seconds or mm per seconds. Shear wave elastography criteria for breast lesions will be the color assessment of maximum elasticity is the most useful method, which is correlated with maximum elasticity values, that is the kilopascal values. The prognostic value for malignancy is directly proportional to the increasing stiffness. So the color coding here is opposite. I have already told. It is approximately, if we are getting a dark blue, so there are just 0.5% of the chances that lesion is totally dark blue. There are just 5% of the chances that the lesion will be malignant. Whereas if the lesion is coming out to be proper red, it is there are high chances, approximately 82% chances, that the lesion will be malignant. The lesions with soft elasticity are represented by dark blue and blue, whereas and are considered negative for malignancy, whereas the lesions coming out to be red in color, they are considered positive for malignancy, or there is high chances for malignancy in them. The lesions with intermediate elasticity are represented by green and orange and are considered equivocal. The lesions with hard elasticity are represented by red color and considered positive for malignancies. Simple cysts or very hard masses, they can appear as signal void lesions because the sound or the waves cannot penetrate into them in the hard masses, so they'll appear as single void masses. And in cases of simple cysts, the total waves will be they won't be reflected back, and they'll appear as single void lesions. So the different values have been proposed in clinical trials with a cutoff range of 50 kilopascals to distinguish benign from malignant lesions. Coming to semi-quantitative assessment, this uses strain ratio as compared to the elasticity of a lesion to surrounding normal parenchyma or the fat in the cases of breast lesions. Strain ratio, it's a ratio of average strain within the lesion compared to the contiguous breast tissue, represents relative rigidity of the lesion. Lesions are considered suspicious if the strain ratio is greater than 3. So the mean strain ratio for benign lesions is around 2.08, and the mean strain ratio for malignant lesions is around 6.28. Thank you. That will be all in elastography. If anybody has any questions, I'll be happy to answer them. What is the time taken to complete liver 2D shear wave? A question by Paul Stephen. It completes within like 3 to 4 minutes. That's it. It just takes 3 to 4 minutes to complete a liver 2D shear wave elastography examination. Uh, Report format for liver. I can uh, I can mail it to you. I'm writing my email ID. Doctor, sure. I'm sending a. I've sent my email ID. You can contact me on email. I can send you the report format also. No issues for that. Reporting format last week. Can you please share? Yes, definitely. For breast also, no issues. I'll share you. You can just write me on my mail and I'll share. If the IQR is greater than 30%, should you repeat all 10 measurements of point share in the liver? No, I won't say repeat all. The thing is, individually you should see the standard deviation. If the standard deviation in individual measurement is more than 30, then you should delete that. If the standard deviation is less than 30 in individual measurements, then you don't need to repeat that measurement. So that measurement is has a higher liability otherwise also. So if your standard deviation in each and every measurement is less than 30, then IQR will all like it will be less than 30 itself. So you need to repeat the measurements, those measurements where the standard deviation is more than 30. Don't you think cost of equipment should go down if these techniques should be useful in day-to-day practice? Look, I can't comment on the cost, but yes, these techniques they're very helpful in day-to-day practice, specifically the breast. While if you see a fibroadenoma or any lesion in the breast, you can just go to Elasto, and the thing is, your report will be better. It's not like some patient somebody is sending you directly for an elastography or something. You need to add these things in your report. You need to upgrade yourself. You need to write if you are seeing a lesion, you need to describe that lesion using elastography also. So that way you will give a better report, and ultimately that will be better for the patient also. That the patient needs to go for this biopsy or not, you can cut down the unnecessarily not required biopsies using elasto. Have good results with strain method in breast. Hitachi method. Hitachi method is not FDA approved, and I haven't used it also since it was not FDA approved. So we here are using I'm using Esote and I'm using Samsung. So where we are using strain in both of them, and they both machines are highly reliable. Candidate between which fibronode to biopsied if multiple? Which fibroadenomas to be biopsied if multiple? Yes, if your strain ratio of you'll get different strain ratios for different fibroadenomas. If the strain ratio is high, or you're getting grade 2 or grade 3 in scuba score, so then those fibroadenomas need to be biopsied, not all. Harder lesions need to be biopsied. Yes, definitely. The harder lesions and the bigger lesions need to be biopsied. Yes. Uh, when do you use and difference of transient elastography with real-time elastography? Look, transient elastography is a blind technique. So you cannot see if you are getting your vessel, or you are getting a non-cirrhosis, or you are getting a liver tumor. That part you are the way you are getting the value from that part. Whereas if you are using proper 2D elastography or point shear wave elastography, it's not a blind technique. You can see the liver morphology, and you can finally adjust your FOV where to keep the region of interest. So that way, I think 2D shear wave and point shear wave, they have a major advantage over transient elastography. And one more reason thing, in transient elastography, the patients with ascites, we cannot do transient elastography on patients with ascites. Whereas in patients with ascites, point shear wave and 2D shear wave, they are we can use them quite reliably. And many patients with cirrhosis, they will have ascites. So using point shear wave and 2D shear wave is better than using transient elastography. Reporting format, yes, I can share the reporting formats, no issues about that. You just mail me and I'll reply back with the reporting format. Experience in cervix and prostate. Yes, in prostate, there are many studies in prostate. We can see the lesions. The harder the lesions, then we need. Then those lesions need to be biopsied. Plus, the same scuba score kind of a thing is applicable there also. If the EB, basically the EB ratio, not the scuba score, the EB ratio is applicable there also. If the lesion is like EB ratio is more than 1 or equal to 1, the lesion on elastographic image is of the same size or larger than the size of the lesion in B mode, yes, then those lesions are definitely uh, more towards the malignant side. But the thing is, the equipment in prostate and cervix, we cannot use transabdominal. We need to get transvaginal scan in cases of cervix, and truss in prostate. In cervix and uterus, I have seen in using this transvaginal ultrasound. I'm doing even shear wave of uh, this leiomyomas or the fibroids. It is very helpful. Both the strain and shear wave, they are very helpful. In cases of small fibroadenomas, some fibroadenomas which are for some fibroids, small fibroids, or the fibroids which are isoechoic and little bit hypoechoic, not much is seen in 2D image. In those cases, when we use shear wave or strain using a TVS, it's easy to get the hard images separately. You will get a proper color differentiation of hard image using strain, and they are easy to diagnose such small fibroadenomas. And soft tissue tumors. Soft tissue tumors, yes, again the tumors will be hard. Not much experience about soft tissue tumors. Uh, they'll be hard, and they'll show the you'll get the blue for such lesions. Those lesions will appear hard on using this thing. But any more questions? No more questions here. Uh, hello, Abhishek. Abhishek, are you there? So that will be all if there are no more questions. Thank you. Thank you, everyone. One more question. Uh, Doctor, what is the value of for malignancy in quantitative breast elastography? Look, the cutoff is 50 kilopascals. If the lesion is showing you more than 50 kilopascals, actually the scale we use for breast is different than the scale we use for liver. The scale we use for liver is from like 30 till 30, whereas in breast it is a much higher scale. The cutoff, what the cutoff we take for malignancy in breast is 50 kilopascals using shear wave. Abhishek, I don't think so. There are any more questions. Abhishek, are you there? I can't hear you. We can't hear you, Abhishek. I think your mic is muted. So, anyways, thank you all. It was a nice session. Thank you.